of the investigation. So 98% sensitivity and specificity for history taking and examination itself. So you can catch those difficult cases also. So on that note, let me brief you today about the important aspects in clinical examination, what you need to do in an acute vestibular syndrome. First of all, being ENT specialist, we cannot afford to miss looking into the ear properly, only because it is a case of vertigo. And we start with doing the hints examination, we start with doing the head thrust, but what if it is a severe middle ear infection? What if it is a huge cholesteatoma, right? Which is giving rise to these symptoms. So we cannot afford to miss looking into the ear. I know it is a very basic thing, but just wanted to emphasize once again. Of course, do the tuning fork tests. Pulse and blood pressure. Going back to our MBBS basics, we cannot afford to not touch the patient and see the pulse of this patient. I mean, honestly, how many of us are still taking the pulse as ENT specialists? So we need to do that. And why blood pulse? Because cases like bradyarrhythmia, tachyarrhythmia, POTS syndrome. POTS is postural orthostatic tachycardia syndrome. Now this is a syndrome where once the patient stands, the pulse rises. So these kind of cases, they present with dizziness and they can very much come to your ENT or vestibular clinic. Okay, blood pressure. Now blood pressure, cases of orthostatic hypotension. What does this mean? Whenever patient rises from a sitting or lying down position, the blood pressure drops, and the definition is more than 20 mm of mercury drop in the systolic and 10 mm in diastolic is a significant clinch the diagnosis. So that's why there is a special way to do this, of course. You make the patient lie down flat for 10 minutes, then ask them to get up, okay? Record the blood pressure once again at 1st minute, 3rd minute, 5th and 10th minute. You can, at why 10th minute and why 1st minute? Because transient, there are cases of transient orthostatic hypotension as well as delayed orthostatic hypotension where the BP will not fall till the 10th minute. That's the reason we need to make them stand for 10th minute and again record if you're really suspecting this, that to be a case of dizziness. And of course, hypovolemia, a simple thing like internal bleeding or a missed abortion, this lady can present to you with dizziness. Why not? So that is how having that clinical suspicion is very important to examine the patient. Of course, take the details, that is alertness and consciousness. This is the moment patient presents to you. If he is not alert and conscious, it should give you a clue. Probably it is a central cause and you should be more prompt. Okay. Voice, facial movements, tongue protrusion, soft palate mobility. All important. Why voice? Dysarthria cases. We know the dangerous Ds. Dr. Shriram has just covered posterior circulation stroke, right? This could be dysphagia, dysmetria, dysarthria. So that's the reason we need to see how well articulate the patient is talking. Is the voice hypernasal or anything? So this could point to your central etiology, rather stroke. Facial movements, of course, the weak side, tongue protrusion, soft palate mobility, these could all point out to your central causes, especially stroke. So be very careful. How to do a Saccades? Here I am doing a horizontal Saccades. I am giving the patient visual clues, the visual cues. There are two ways to do it. Either you say right, left, or you wiggle the finger and ask the patient to follow. This one is how a vertical Saccades is done. Audio please. AV team? Audio nahi aa raha. Okay. Anyways. So Saccades, why is it important to do a Saccades testing? Because it is one of the central oculomotor tests. What I mean by this, if let's say you get a hypometric Saccades. Now, what do I mean by hypometric? That means, let's say I ask the patient to look to the right finger. The patient's vision will stop short of the finger and then make a step and go to the finger. So that is a hypo. What does a hypermetric means? They will overshoot the finger and then the gaze will come back. So hypermetric Saccades, inattention or poorly understood instructions by the patient can also give rise to poor Saccades. So this or a continuous insomnia or poor previous night sleep. These are some things which can also give rise to poor Saccades. Affected Saccades point to cortical involvement. So that is why it is important. That is how you document Saccades. Now let me show you smooth pursuit. What is a smooth pursuit? Basically, you ask the patient to move their eyes and follow the target with a smooth movement. Okay, follow a continuously moving target with a slow in a slow motion. So that is how it is. So we'll understand with the help of a video. So ideally, if I ask the patient to move the follow my finger, the movements of eye should be smooth. But you can see there, the eyes are taking multiple steps and then following that is how they are following the finger. So this is a saccadic smooth pursuit. I hope everyone could appreciate it. Yes, the eye is not able to follow my finger smoothly. It is taking multiple steps. So this is a saccadic or a broken smooth pursuit. Again, points to a cerebellar etiology either directly. So you can make diagnosis of that level only by your clinical examination. Vestibular migraine cases, the smooth pursuit will be affected. Of course, for those of you who are interested, especially for the PG students, this is how it looks on VNG. I've added a vertical smooth pursuit here, and that below there is the graph. You can see there is a step ladder pattern, right? So that is a broken pursuit, how it looks on VNG, the video and the graph. That is how you document pursuit. Check the full range, check the tracking of the eyes, right? Horizontal, vertical. Of course, check the eye movements in all the 6 cardinal positions of gaze, either with an exaggerated X, typical, coming back to our ophthalmology classes, right? Or make an exaggerated H. Look for full and free movements, smooth movements, yes or no. If any restriction, if any palsy, you can come to know at this stage. Okay? Cannot emphasize more on the importance of the head impulse test. One of the most important tests to test the vestibulo-ocular reflex, maintains vision, we know, during fast head movements. A positive test points to, it's a good thing. It is one of the tests, if it comes positive, we know it is peripheral. So we are happy. In fact, a negative can mean central. Okay. Of course, in vestibular neuritis cases also, this is very significant. It comes positive for quite a long time. So I'm showing a head thrust in a child. He is 10-year-old. Okay. Now, yes, in this test, one important thing, instructions to the patient, always keep them to, ask them to keep their neck free, ask them to look either at your nose or between your eyebrows, and tell them, and do not move the head more than 10 degrees on each side. That is some people do like this, or, they just overshoot, not like that. That's not the correct way to do a head thrust. It should be 10 degrees on each side. So let us see what happened in this case. So I've asked him to look at my nose, but clearly the eyes have slipped off the target and then they are coming back in steps. Can everyone appreciate this? Yes? Okay. And this case is a bit special because it was positive on the other side also. See, notice that the eye slipped once again and came back with 2 steps, right? Skew, test of skew. So this is the alternate cover test. Cover the eye for 10 seconds, swiftly move to the other eye, look for any refixation, okay? Or any vertical misalignment that you see. That is a skew deviation. Of course, this is mainly due to disturbance in the pre-nuclear inputs at the nuclear level. Correct? That's how you document. Look for head impulse, skew deviation, pupils, always. The size of the pupils, equal, unequal. Elaborate that. Nystagmus, of course, we know, we look at nystagmus in the right gaze, left gaze, up gaze, down gaze, center gaze. With fixation, without fixation. Diplopia charting. Why diplopia charting? Again, coming back to the same. Dangerous Ds. One of the dangerous Ds is diplopia. So diplopia, dysarthria. Again, not to miss out a stroke. Always take history of diplopia very seriously and do the examination in all the quadrants. Test of 2-2-2. Now this one is a very nice and a recent addition and very simple test but beautiful test. I learnt it from Dr. Srinivas sir. What is 2-2-2? 2 sensations, okay? Temperature and pain. 2 sides of the body, temperature and touch, fine touch sensation. 2 sides of the body, right and left. 2 regions of the body, face and body, okay? So how do we test for 2 sensations then? Temperature and fine touch. A tuning fork is available in everyone's OP chamber here. Yes, easily. So how does a tuning fork normally at room temperature feel? If you check, it feels cold. So a simple tuning fork, by that we can check. And cotton wisp is available in everyone's OP again. So that is how you ask the patient to close the eyes and check on both the sides. Of course, both the sides and head, and then on the arms. We'll understand with the help of one case I had seen with Dr. Srinivas sir only at Bangalore. So again audio is missing. Audio important tha iska. AV team, please help me. Anyways, I'll try to explain you what is happening here. So sir, as you can see, is checking on the right side of the cheek. Patient is saying yes. Just try to see the gestures for now. So he's saying yes, he can feel it is cold. But on the other side, you know what happened? He said, I can feel it, but I can't say it's cold or not. I cannot say. Okay? Then this is sir is checking for pain. Right? He can say, I can feel the touch, that you are touching me, but I cannot feel that you are pinching me. I cannot feel the pain. Any guesses for this diagnosis? Positive on the left side. So he has lost, let me tell you, his temperature sensation and pain sensation on the left side. So you can see, sir is checking on both the sides, right, left. So this was a case of right lateral medullary syndrome. Okay. To a stroke. And finally, coming to the cerebellar test, we cannot afford to miss the cerebellar, not doing the cerebellar test like the classic heel sheen test, the finger nose test, and the dysdiadokinesia. Okay. So that is how. Finally, make the patient stand. Okay, we cannot. A central patient with a central disorder will not be able to stand. Patients with even very bad or severe cases of peripheral will be still able to stand. Okay, a patient with cerebellar lesion, even with minimal support. And how do I define minimal support? A simple thumb. Even if you give them a thumb support, they are like sort of able to stabilize themselves. Got it? So that is how make them stand finally. And if all of this above tests, whatever I described, are normal, then screen for BPPV, which will be covered in the subsequent hands-on. Dix-Solpike, McClure-Pagnini, supine roll test, do them. Thank you for your patient listening.